Well, welcome. Tonight we're going to talk about a topic that unfortunately seems to affect a couple 100,000 Americans a year. That it looks like we're making progress, but we wanted to get an update. So why don't we start with introductions?
I'm Tanya Lingos, Radiation Oncology, and I am the former medical director and current director of network development in radiation oncology over here at Milford at the Dana-Farber Brigham and Women's Cancer Center at Milford Regional Medical Center.
My name is Itai Pashtan, and I'm one of the physicians within the group.
So now we're talking about breast care. Because I remember the first time we did a show when I said breast cancer, it was like, no, we want to look at the overall steps we should take. Are we winning?
Absolutely. I mean, the statistics show that we're doing better and better in combating breast cancer, in curing the women who get it. But it's a very common cancer, so many women are going to experience it at some point in their lives.
I saw the CDC survey said over the last 8 or 9 years the mortality rate was down 2%. Can you feel that? I mean,
I think you can feel it, and there are many things to these statistics, because as Itai says, it's a very common disease, but we've also gotten better at diagnosing it. So we are diagnosing some tumors and at earlier and earlier stages to the point where it's become controversial. Have we gone overboard in terms of diagnosis, and are some of the things that we're calling cancers not really cancers? So that being said, if you treat those patients and you throw them into the pile of patients, you're going to get better survival statistics. At the other end of the spectrum, however, I would say that we all agree that we've gotten more and more specific and more effective treatments so that patients are living longer and patients are being cured more, and the whole controversy over whether mammograms save lives or don't save lives is still brewing, but I think a lot of us
I want to talk about that because, you sit there and say, I look at the CDC and said, what was it, 5-year survival rate is 89%. That sounds like we've made a lot of progress. And the mortality rate being down 2%.
Right.
I mean, for once, 2% seems like a very significant number.
Well, I think that that's right, and when you're talking about 250,000 people a year being diagnosed, then 2% is a big number. And I think the other thing to take into consideration is that breast cancer can be a disease of very young women, so you're really talking about women being diagnosed at the most important productive times of their lives and affecting not just them but their whole families, and so it's a huge number.
And again, I mean, you know better than I, but when I looked up 11% of breast cancer diagnoses come from women under 45.
Right.
Does that sound right?
Yeah, that's what we see in our clinics.
So now I got this whole problem, I guess, with saying mammograms aren't needed or aren't needed as often. I know my opinion. It's, if you hear, well, Dr. Itai, the good news is 99% of the patients survive the operation. Bad news is you're the 1%.
Right.
Yeah. I don't get it.
I think you're right. For the individual patient, they want to get the diagnosis as early as possible. But if you're screening every single woman in the country, there's the potential for some. First of all, it's not necessarily the most comfortable procedure. So it's not an easy thing to go through. It carries with it anxiety, physical discomfort, and a little bit of exposure to radiation from the procedure itself. But there's also something called a false positive, where a test will be done. You'll think that something is there, something that might not really be there, and it'll carry with it then the next steps, which include a biopsy, which is also very uncomfortable. And every time a needle pierces the skin, it carries with it a risk of an infection or a hematoma. So it's always a balance. We want to diagnose as many patients correctly as soon as possible, but we don't want to cause complications or anxiety that's not necessary.
We're having the same thing. I mean, the whole diagnostic of BRCA1, BRCA2, isn't it the same as the prostate? The people are worried that the false positives will cause unnecessary angst.
Right. And what we've seen with prostate cancer is that we were diagnosing people at earlier and earlier stages because of the sensitivity of PSAs, and then the findings came out possibly that too many men were being treated for prostate cancer. And the same thing is going to be happening with breast cancer as well, that we are going to be treating too many women with breast cancer. And I think it's important to understand that there's a spectrum of what cancers are. So here are normal cells and here are cancer cells. And then in between, there's a gray zone. And whether from here up is cancer or from here up is cancer, it's hard to distinguish. So the biggest controversy revolves around everything in that gray zone, both with prostate cancer and with breast cancer. And if we're biopsying and calling something a cancer that maybe just could have sat there for the next 10 or 15 years and done nothing and not caused any problems, then we're treating too many people. And it's very expensive and it's morbid and there are a lot of side effects and it really affects people's lives completely.
Now, we keep saying women, but if I remember, for every 100 women, there's one male.
Right, right.
You know, when you talk about 220,000 diagnoses a year, there's still 2,000 guys out there.
That's right.
That I diagnose.
And in men, actually, it's usually diagnosed at a later stage because it's not something that people think about, and it's harder to really detect a mass, and obviously men are not getting routine mammograms. So in men who have a family history of breast cancer in their mother or prostate cancer as well, and even the BRCA1 and 2 mutations, then they should be checked carefully.
Well, when you say uncomfortable, I happen to be one of those people 30 years ago.
Wow.
Where the physician said, you have a lump. And back then, since I'm a guy, it was like, there wasn't even a question. They're just going to hack it out. Well, they made me go into that machine. I'm absolutely convinced it was designed by a male designer going through a bad divorce. It's how much pain can I endure?
Oh yeah, it is not comfortable.
And then when you don't have a lot of tissue to begin with,
Yeah.
cracking and screwing.
Yeah, yeah.
But it is something that you see 1% of the diagnoses being male also.
Right, right.
To the layman, what causes breast cancer? You know, you hear, well, if your breasts are denser, if you have dense breast tissue, but to a layman, how do you explain what is breast cancer and why is it there?
It's a good question, and I think you can ask that about any cancer really, but there's a few reasons that we know why a cancer happens, and they can include having certain genetic mutations like in the BRCA1 and 2 genes that you mentioned that put you at a higher risk of developing a cancer. The vast majority of patients, we really don't know. It's just a random effect that might have happened, or there might be other genetic factors there that we just don't know about yet. Or there could be some known risk factors as well that we're aware of. Like, for example, if a woman has been pregnant over the course of her life, or if she's breastfed, or if she's taken hormone replacement therapy, things like this can have
Radiation treatment when they were kids.
Yeah, exactly. Yeah, so there's certain things that can increase your risk of getting a breast cancer by a small percent, but still, for most of our patients, we can't point at one specific thing and say, this is why you got breast cancer.
But now, when you hear dense breast tissue, again, to the layman, dense versus not dense, what does that mean?
It means that when you're looking at a mammogram, it looks more like solid fibrous tissue. It's opaque, and you can't see the fibrous network of the connective tissue in the blood vessels. And so it can, when we're looking at mammograms, we're looking for microscopic dots of calcifications, early stage breast cancer, so smaller than a pinhead, basically. And if there's dense tissue there, you're just not going to see as much. So younger women have dense tissue. Some families, it runs in families. Usually after menopause, the breast tissue becomes less dense, but it definitely can obscure a breast cancer.
But it's not something that a person can take steps not to have dense breast tissue.
No, definitely
I mean,
not.
you're either born with it or not.
Correct. And a lot of this is all related to estrogen, I think, in the body. So we do know that estrogenic levels, higher estrogenic levels may predispose a woman to, or a man, but may predispose you to breast cancer. So, and that will be the same sort of background that may make your breast tissue more dense than other situations.
For that reason also, mammograms are generally more useful for women that are older, and they're better at picking up a cancer in a woman that's older. In a younger woman, a mammogram's not going to be as useful because generally the breast will be denser. So that's part of, I think, what's come into play in the conversation of when should a woman begin having mammograms. If you start screening, there's some women in their 30s will have breast cancer too, but we're not screening women in their 30s with mammograms, and that's part of the reason it's not going to be very useful.
But now, I mean, I can see the medical ethics argument. If we screen all these women at 40, you're only going to pick up an extra, under 45, 11%. If you took that money and put it into the inner city programs, you could save 1,000 more people. But what do you say to the 10%? I mean, if that's my mother, my darling bride, or my sainted children,
Right. That's right.
boy, that percentage means a lot.
It's a big problem. It's a huge ethical problem, and healthcare dollars are going to become more and more tight, and we're going to have to start making these painful decisions. And it is really, it's interesting because if you look at racial disparities in the terms of diagnosis of breast cancer, you can clearly see that women who are of African American or Hispanic descent are diagnosed at later stages because they don't have access to mammograms as easily. They don't know that they're worthwhile, or sometimes they're afraid of having a mammogram.
But that's just access. That has nothing to do with genetic disposition or anything.
They're still sorting that out. I
Oh.
think in some people it may be more aggressive, but. if
But
you
wouldn't
look
that be the
stage by
same
stage-
if you were if you were white? If you're not getting diagnosed as often, aren't the odds higher that
That's
it's going
right.
to get caught later?
Right.
So now the new standard of care, let's call it, when would the government say you should start being screened?
It depends who you ask. Yeah. There's a lot of organizations out there. I mean, the American Cancer Society is still recommending age 40. I think the United States Preventative Task Force is recommending a slightly older age. There's a lot of agencies out there making recommendations.
Okay, I'm going to be mean, and I'll apologize, but Itai, I send you my daughter, my darling bride, or my mother, and they say, when?
I would say 40.
Yeah, I would say, 35 to 40, and it depends on family history.
That's right.
So if you have other risk factors or something along that line, then it's a clinical decision, but I would say 40. And it doesn't have to be annually after 40. Although you and I have both seen patients who had a mammogram at 40 and then waited at 42, and by the time they were 42, their tumor was bigger than if they had come in at 41 would have been detected at that point in time. You can't tell. We don't know
Yeah,
for
that
certain.
being said, even women who are getting screened once a
That's
year,
right.
they won't have a cancer, and then a year later they'll have a very advanced cancer. So these things can pop up at any time.
What does a mammogram cost?
Small. It's like 160 or so. It's a lot of hospitals will, it's a loss leader basically for a lot of hospitals. So it's not that the mammogram itself costs so much, but when you go for mammogram, there's a charge for the facility and the images itself, and then there's a charge for the radiologist's read. The problem is that when you end up getting a biopsy, then you go for an ultrasound, you have an ultrasound guided biopsy, and then there's a pathology.
But for an
One thing
initial
snowballs.
screen, it's $160.
It's, I think
Under
it's under
200.
200, yes, I think so.
Under $200.
Right.
Wow. I guess if you can afford it, kind of hard to say if there's any risk factors that not a good investment.
And there are programs in the state all over the place that will subsidize and underwrite mammograms for women who have.
Who can't afford it but have.
Yes,
Okay.
right. So it is important.
So now, when we talk about breast cancer, and again, I am not an MD, so when I read about the ductal or the lobular, okay, can you explain that to people who, I can imagine the minute you hear breast cancer associated with anybody you know,
Right.
you're going to jump on the internet,
Oh,
you're going to
yeah.
become well-versed.
Yeah.
But what's the difference?
Well, I mean, the breast is made up of various cell types, and the most, the lobules that help produce milk, and there's ducts that carry the milk towards the nipple. And these are the cells that oftentimes become a cancer. So lobular carcinomas originate within the lobules of the breast. Ductal cancers originate within the ducts.
And more breast cancers are ductal carcinoma than lobular carcinoma. I think the other thing that's challenging about lobular carcinoma, so ductal carcinoma will often show up on a mammogram as little microscopic calcifications, small calcifications. Lobular carcinoma tends to have a different texture, so that sometimes a woman say, oh, I felt a rock hard mass in my breast, but other people say, well, it felt kind of mushy and fleshy, and it didn't really, and that can characteristically be lobular carcinoma that can evade diagnosis and just sort of go under the radar screen of a mammogram as well.
But then you also have further breakdowns of, inside, outside. So in situ versus, when you think about invasive. Okay, back to the old chemist who doesn't know medicine. Can you explain that one to me?
Sure. Yeah, I mean, so if you think about a duct, and the example I'll use will be ductal because that's by far the most common kind of breast cancer. But if you think about a duct as a pipe, for example, ductal carcinoma in situ is an abnormal proliferation of these ductal cells within the duct, within the pipe. It's still sitting inside of it. And really, we only start to worry about cancers in the traditional sense of spreading to lymph nodes or going somewhere else when it's invaded outside of that duct, when it's broken through the walls of the duct into the breast tissue itself. And that's an invasive cancer when it's outside of that.
And that's when it becomes life-threatening, because once it's broken through the wall of the duct, then it has access to the blood vessels or lymphatics, and that's when it can spread to other parts of the body and metastasize. And so before the era of mammograms, we did not see much ductal carcinoma in situ or stage 0 carcinoma, which is not life-threatening in and of itself, but left untreated, it could become invasive. And we say about 50% of them can become invasive, but the question is which of those 50%? So if you're a person who's got a non-invasive stage 0 ductal carcinoma in situ, do you want to be the one that they do the experiment on to say, oh, don't do anything about it, or do it? So that's where some of the controversy comes in. And so when we treat breast cancer, we think about many different components. One is the local component of the problem in the breast itself, and the other one is there a risk of it spreading or metastasizing to another part of the body. And that's where we get into the whole situation of surgery versus radiation versus chemotherapy versus hormonal therapy. So if it's in situ or in situ and it's restricted to the breast and it doesn't have the capacity to spread, then you can treat it with lumpectomy with radiation or mastectomy, or in many cases lumpectomy alone, which is where the momentum is going in that direction, followed by some hormone treatments, and that will take care of it. And the goal would be to diagnose these cancers at that early stage, right before they have spread to the lymph nodes, because once it's spread to the lymph nodes, then the survival becomes more of a challenge.
Now, realistically, as we said before in prostate cancer, people worry about the side effects and all, and I always sit there and say, okay, behind door number 1 is death.
Right.
I really don't care behind door number 2 or 3. It's better than door number 1. When somebody's diagnosed with breast cancer, when you say wait,
Right.
I mean, is this something like, when you think of prostate cancer, that you could go 10 years and nothing happens?
I wouldn't say 10 years, but there are a lot of similarities between prostate cancer and breast cancer, and both of them are considered slowly growing cancers. They're not like lung cancer or rapidly growing lymphoma. So you have the luxury of time, of waiting. Sometimes people will go to their graves with this cancer that's not been life-threatening and it's not going to curtail their survival. Other times it's a dangerous situation. But even still, you have the luxury of time to go through a logical series of tests and therapeutic decision making.
Yeah. I would say, sometimes I meet patients who tell me, from the moment of the diagnosis, they wanted that cancer out
Right.
5 minutes ago
Right.
or a
Right.
day ago. And what I usually tell them is that it's much more important to treat something well and correctly than to treat it fast. So it's very
mentally.
Yeah, it's very difficult for people. And for that reason, we have at our centers social workers and a lot of support services, because the cancer diagnosis, it opens a lot of issues, and it's not just treating the cancer, it's psychological, it's family, it's
When we get
a
into
lot of
treatment, you
issues.
sit there and I know that, okay, if you tell me it's my time to take the big bus ride, and hopefully it's north, if they hand me suntan lotion, I'm not going to be happy. But I've had a great life. I don't want to buy the bus ticket, but I can deal with it. But my darling bride who's been the rock, the foundation of our family, my sainted children, mentally, that's got to be
Yeah,
just
yeah.
unbelievable as far as strain on the rest of the family, because you want to do something to help.
Right, and it's really, it's not, it doesn't just affect the patient, it affects the whole family. The partner, spouse, the children, if there are children, the rest of the family as well. There's a lot of guilt associated with it, I think, because you do see that some breast cancers run in families, and so lots of times patients will say to me, oh man, I hope, you know, my genetic testing is negative, because what am I going to tell my daughters otherwise, or something like that. So it
Oh,
really
wow.
is, yeah, it's
So
it's
part one of any treatment is to get with the program and deal with the social, the psychological aspects, so that you are, how do I say this? So I'm not being silly, trying to be supportive. So I'm doing the right thing to be supportive.
You are definitely doing the right thing, but don't be surprised if your efforts are not embraced the way you think that they should be embraced, because sometimes that will happen. And it's hard. It's hard. You want to be supportive, and sometimes the patient will be very grateful, and sometimes the woman will say, yeah, you're not going through this. This is
But
not your
that to
problem.
me is probably the biggest reason that you go to the social worker environment,
Right,
is to
right.
sit there and say, okay, what can I expect?
right, right.
You know?
And it's also good to get all of your opinions up front, because then you can formulate a plan. And you know, fear of the unknown is terrifying. And if you are armed with knowledge and you know exactly what's going on, then you can face everything step by step in a logical manner. And that's why it's not a rush type of situation. And as you say, 89% of all women with breast cancer are going to survive. So you want to figure out what is the best chance for survival, and along that path, what's the treatment that's going to be best suited for you? What's the least morbid and easiest to
So
tolerate?
now, 4 basic treatments. Explain to me the options. When do you go with chemo, hormone? When do you go under the knife?
Yeah, so I mean, in essentially every situation where you're trying to cure a patient, you'll have a surgery. And the surgery will be first, if it's possible to do the surgery up front in a way that's going to lead to a good cosmetic result, for example. Sometimes treatments do start with a systemic therapy. We call systemic therapies treatments that go all over the whole body. So chemotherapy, which is something that goes into the veins, that we call that a systemic therapy. Those therapies, sometimes we use them up front if we want to shrink the tumor before the surgery. If, for example, we want to spare the breast and do something called a lumpectomy, just taking out the tumor itself, then we want the tumor to be small relative to the breast so that we can end up with a nice cosmetic
When
result.
we read about or you talk to oncologists, it seems like if it's a target, they go at it with radiation. If it's metastasized or spread,
Correct.
then you bombard the body by going after the chemo, using chemo.
Right, right.
It sounds
Yeah.
almost the opposite here.
Well, so generally that's right. I mean, if we're worried about disease being elsewhere, then we use a systemic therapy. And sometimes even if we don't know that the cancer is spread, if we have no evidence that it's spread because our scans aren't good enough to pick up those tiny things, but we know statistically that for some patients they already might have had cancer that's spread, then we bring in these systemic therapies to try to address any cancer that may be outside of the breast too. And sometimes we do that before surgery, sometimes we do it after
Well,
surgery.
when would you choose radiation versus, I mean, if you found a spot or two?
Two separate columns, two separate conversations. So radiation and surgery are local therapy, and chemotherapy, hormonal therapy is systemic. as
Broad-based,
Itai
it's
said.
systemic.
Yes, broad-based. So every single breast cancer patient has to have two bases of decisions. So even if you have surgery or radiation, you still have to make a decision about chemotherapy or hormonal therapy.
Just in case?
Just in case. And at that is an estimation of what your risks are of this disease being elsewhere in your body. When it comes here towards the local therapy of breast cancer, the movement is away from mastectomy now, and in fact now the recommendation is really to do a lumpectomy followed by radiation, because that offers the same survival as mastectomy, and it's less disfiguring and usually easier to tolerate. So that you do the least amount of surgery possible now, and then you sort of, radiation's good at mopping up microscopic bits of cells. And so we would treat, instead of removing the whole breast now, we know that if you would just remove the diseased portion of the breast with a rim of normal tissue, you can follow up with daily radiation treatments that are either 4 or 6 weeks in
Now,
duration.
when you talk about a lumpectomy,
Mm-hmm.
give us an idea. I mean, how big of a chunk of skin and tissue are you taking out of a person?
Walnut, it depends on the size of the tumors, but really sort of anywhere from cherry size to walnut size, and that's what Itai is saying, is if someone came in with a tumor in her breast that was the size of an orange, to remove that, you're going to be causing a lot of disfigurement. So what we often do at that point in time is we say, well, it's that size, and there's a likelihood of lymph node involvement or disease in the body. So we start with chemotherapy up front, and
shrink it down.
And then you can do a smaller amount of surgery, and it works very well. And breast surgeons are very, very talented at being able to, they don't so much take the skin out unless the tumor is involving the skin. They make a small incision, and then they can dissect down to the area that's involved, remove that, and then they can sort of reapproximate the breast tissue to reconstruct the breast. So it really has a very nice.
Yeah, it's incredible.
to it.
Some
Yeah.
women have these surgeries, and you look at their
it's
breast and you
wonderful.
can't even tell that they
Right.
had a surgery.
Right.
Well, I mean, that's got to be, from a psychological point of view.
Enormous.
And again,
Right.
door number one comes to mind.
Right. Right.
And
Right.
you get to a point where, at our age, I mean, the husbands will have no concept
Right.
because,
Right.
come on.
Right.
Door number one, or anything you do.
Right.
This is my best friend, somebody I've been married to for 100 years. I want her alive.
Alive. Well, and so it's very interesting, because when I did my residency decades ago, the whole role of lumpectomy versus mastectomy was very controversial. It was when Nancy Reagan had her surgeries. And so they were saying, the surgeons used to say to patients, if you want to save your breast, have a lumpectomy. If you want to save your life, have a mastectomy. And then the data came out that there was no difference in survival. And so the roles were reversed, and they actually had to legislate. I mean, the states had legislation passed that surgeons had to inform a woman, because as you say, as soon as you get diagnosed, the impulse is just take it off. Don't even take one off, take both of them off. I don't want them anymore. I don't love them anymore. Because I just want to be alive. But you're not, yes, but the fact of the matter is that you're not going to live longer if you have a mastectomy in the vast majority of situations. So there are specific circumstances where you do need to have a mastectomy, but not in the vast majority of cases.
I was going to say, isn't that becoming less and less
Much less.
the case?
Yeah.
It's very geographical. Yes. It's
Okay, wait a minute. Help me understand. It's very geographical.
Yes. So if you look at data across the United States, there are parts of the country where mastectomy is still more common than lumpectomy. But in the Northeast, fortunately, in Northeast and Atlantic seaboard and along the West Coast, most women have lumpectomy with radiation. In the South and the Midwest, a lot of women are still having mastectomies. And if you look at specific communities, it's very much also related to socioeconomic level. So it's important to
Wait a
spread the
minute.
word.
I mean, this is going to sound crude, but what person would choose to take a large amount of tissue when they don't need to? I don't get it.
Well, like Tanya mentioned, some of it is fear.
Yeah.
Some women, as soon as they have the diagnosis, they just say, just take the breast off, take the other one off too, because I never want to have to experience this again.
Oh, okay.
So part of it is a fear factor.
And it's very interesting, we're seeing a generational thing with that as well, that the whole incidence of young women with breast cancer, the movement towards bilateral mastectomies and a preventative mastectomy, a prophylactic mastectomy on the opposite side has become very common now in young women, because they just say, I don't ever want to go through this again.
And they saw Angelina Jolie
Yeah,
do it.
it's called the Jolie effect. I mean, that's what
Yeah,
it's called.
but in some situations, it might actually be worth considering. For example, if you have these BRCA mutations, which she had, and that's why she pursued that, but it's not something that should be applied across the spectrum.
Seems awful radical.
It is. But there's so much
But
fear
again-
associated with this disease that's so common.
I can't imagine my role would be anything but whatever my darling bride decided. You know, because you mentioned if psychologically she's going to be suffering
Right.
because, okay, I had a problem on the right side,
Right.
and I'm always going to be looking on the left side as a problem. Well, then, what am I to say except, you know, do what makes you the most comfortable?
And that's the right answer, but there are times when that's not what the conversation is that goes on. And so it becomes very, very challenging. And not everybody's lucky enough to be in a relationship that's incredibly supportive and understanding.
I mean, something as minor as when I tore my ACL. Okay, so I'm still playing hockey, kind of. Not as well. And my darling bride said, you should go for the surgery. And I said, yeah, but not till I'm 60. My goal is to be on the ice with these 18-year-olds till I'm 60. And all she could say is, it's your leg. And I mean,
we
that.
can talk about that offline, because I've had that exact same surgery, and I'll fill you in on that.
But, you know, you sit there and say, okay, that is 1/100th of 1% the
Right.
issue you're dealing
Right.
with. And yet,
Right.
what she told me that meant everything was, okay, you're being dumb, but if that's what's going to make you feel good, we'll put it off till
Right.
you're 60.
Right. Right.
I can't imagine that I would take any approach more than whatever you decide. I mean, this is my best friend.
Right.
Cosmetically, you got to be kidding me. I'm almost 60 years old. I'm going to worry about
Right.
cosmetics.
But not all breast cancer patients are that age. I mean, we have patients who are in their early 30s, and it's a huge issue. It's a huge issue.
Yeah, and because fear plays such a big role in this, you really want to go see doctors in a clinic that you really trust, in a place where you might be able to, you know, talk to a radiation oncologist, talk to a medical oncologist, talk to a surgeon, get all of those opinions in a supportive setting with, you know, available social work, so that the decision that you come to is an educated and well-guided decision.
Well, and again, if I'm talking to a medical oncologist, I'm talking to a surgeon, my mind is saying he's coming with a knife. You know, his expertise, I'd want to talk to all four
Yeah.
and then
Right.
make an informed decision.
And that's the best way to do it. So that's why most centers have multidisciplinary clinics, so that at the time of diagnosis, you can see or get input from the surgeon, the radiation oncologist, the medical oncologist, all at the same time, and have access to a genetics counselor if you need it, social worker, if your family or your children need support. Those people are all available.
And that to me would be the most important thing, is make an informed decision.
Right.
I'll never have your level of expertise, but I sure want to know that I explored.
Right.
And when I go rent a hotel, I call 4 places,
Yeah.
right? Something that's
Exactly.
going to deal with,
Right.
you know, 12 hours of my life.
Right.
Yeah.
And that's the important thing for patients to understand, is not to panic when they're given the diagnosis, that to take a step back and take a deep breath and say, okay, I'm going to gather the information and gather the facts and make a wise decision that nobody will regret and is not
So now when we
reversible.
talk about diagnoses, you know, ultrasound, MRI, what do they call it? Diagnostic X-ray. You know, when I want to be medium well or medium rarium, and then biopsy, harpooning me. How do you? Is there a progression level? I mean, where do you start, or do you start with, you know, the BRCA1, or BRC1, BRC2 test? That's a lot less invasive.
But that's only for certain people. So generally speaking, the approach is different for every single person. If a woman has a mammogram that's abnormal, a regular routine annual mammogram that's abnormal, then that goes to the next step of a diagnostic mammogram.
So abnormal is you find a lump or something.
Not necessarily. If the
mushy or-
radiologist will say, oh, we see 6 or 7 calcifications that are too small to be felt, but we need to take a magnification view to look at that a little bit more closely. So then she goes back for a diagnostic mammogram. And if that is still there persisting, then they'll say, okay, this looks like we may need to biopsy.
Okay, you're jumping ahead on me. You got a mammogram,
Right.
and then you say a diagnostic. Isn't a
Right.
mammogram a diagnostic?
So there's our screening mammograms. So when you go
okay.
for your annual test, that's called a screening mammogram. When they have to go back and take a second look, then they send you for a diagnostic, same test.
So the
but they're looking
technician
at it.
found
Right,
something that
right.
isn't quite, so
Right.
I'm going to hone in on
Right.
the
Exactly.
white spots and
Right.
magnify them.
Right, right.
So that's still another smush, but it's a diagnostic smush.
Exactly.
And then they make a decision about a biopsy, and then the biopsy can be done either by ultrasound or stereotactic. The other approach is to someone will say, oh, I felt a lump in my breast, and everybody can feel it, but they do a mammogram and nothing shows up on the mammogram, so then they'll go straight to ultrasound or to MRI. But so
No, a biopsy, the only biopsy I ever knew is they take a large harpoon and go
Yes.
in and
yes.
excise tissue.
I
So
wouldn't call it a large harpoon.
That's because
more
you're
of
on
a-
this end of that needle. It's always perspective. When
Yeah.
you're the physician, it's a very small canyon. When you're the patient, I see this large harpoon coming at me. But
close your eyes.
yes. But realistically, when you say a biopsy,
Yeah.
there's more than one type of biopsy?
Yeah, there can be two kinds. It really depends what the best way to visualize the tumor is, because the point is to just put that needle, not a harpoon, through the area that you need it to go through, and whether that's best guided by a mammogram or whether it's best guided by an ultrasound, whichever way shows it
Okay,
best
so
is
the
for
ultrasound
biopsy.
is going to help you direct.
Exactly.
So you
Yeah.
take the shortest path and the least
Exactly,
pain.
right.
But it's still a needle.
Oh, it's not fun.
Oh,
Definitely.
I was
It's
going
not
to say,
fun.
I mean, you're
No,
talking
no,
about
no, no.
ultrasound, I'm saying, okay, to get the tissue out, I can't ultrasound and shake it out, okay.
No, no, and so then once the diagnosis is confirmed with that tiny needle biopsy, then they'll go back and say, okay, let's do some more imaging, let's determine the size of that lesion, let's see if there are more than one lesion in the breast. Sometimes they do an MRI, but not in everybody, it's not necessary. And then they'll decide on surgery, what type of surgery, and they'll decide on whether the lymph node needs to be sampled because it's an invasive or a non-invasive cancer. Non-invasive cancer, you don't need to worry about the lymph nodes.
No, the lymph nodes haven't been affected yet.
Correct, exactly. If it is invasive, depending on the age and the stage and what it looks like under the microscope, then you decide to sample the lymph nodes. For the BRCA testing, that's done in women who have a very strong family history or are Ashkenazi Jewish ancestry, who have multiple family members who are infected, because it's not a common mutation. So the fact remains that most breast cancers are not related to any genetically identified mutation.
But if I am of that subgroup,
Right.
then the BRCA test seems to be the easiest, quickest to start with.
Well, you wouldn't do that for a diagnosis. You would only do that, either you would do that because you know you have a strong family history,
Right.
you have the risk factors, then you would do it, and then that might guide further screening or
treatment
doing
decisions.
or doing something prophylactically. But otherwise, thinking about BRCA comes typically
That's a
afterwards.
secondary, it's not
Correct.
a screening.
Right.
Definitely not, no. Generally, it happens at the time of a woman's been diagnosed with breast cancer and she's trying to decide, do I want a lumpectomy or a mastectomy? And if the BRCA testing is done and it comes back negative, then they'll say, okay, let's do lumpectomy with radiation. If it comes back positive, some women will say, then you know what, I'm going to do what Angelina did. I'm going to have bilateral mastectomies. I'm done with this. I don't want to have any more issues with it. And so that's usually the decision tree. And at that point in time, if a woman turns out to be positive, then you might go to their family members, their siblings or mother or children and say, this is what the pattern looks like. You may be at risk for it. Do you want to have genetic testing done?
But now you mentioned you're as much a cosmetic advisor as an oncologist at some point, because you're trying to minimize, especially, I mean, let's face it, at 50, 60 years old, yeah, it's a whole different game than if you're going through the mating ritual, you know, from the beginning at
right.
30.
Right,
I mean, I got to believe
right,
that at 30, the cosmetic end is going to have a major impact.
right,
Whereas at 60, my God, we've been married 100 years. I mean, the cosmetic piece,
right,
if there's any risk of door number one,
right,
I can't
Right.
imagine I would care.
right.
But it seems like we've come a long way if you say you're doing lumpectomies and you can't even tell.
Yeah, we've come a long way, and there's more progress being made. And I think the other thing that's important is that surgery under the arm has changed and evolved as well to be a less intrusive and less extensive procedure, which is great because decades ago, some of us may remember grandmothers or something who had very swollen arms and lymphedema from having had 20, 30 lymph nodes taken out under their arm, and a full radical mastectomy where they used to take the pectoral muscles and really cause a lot of morbidity.
But aren't the imaging agents coming out now really helping to minimize?
Absolutely.
I mean, when you think back, 100 years ago, I'm being facetious, but a long time ago,
right.
it seemed like all lymph nodes bad.
Right.
They're all coming out.
Yeah. So these days, and for many years already, the surgeons have been doing something called a sentinel lymph node biopsy, where what they do is they're able to identify what is the first lymph node that this cancer would go to. And so they can just hone in, take out that one lymph node, look at it underneath a microscope, and see whether it actually did or didn't. So that's a huge advance.
Now, Itai, again, take a step back. What's a lymph node?
So a lymph node, you can kind of think of, so we have lymph vessels that course throughout our whole body. Most people don't really think about them. They think about the blood vessels. But we've got lymph vessels throughout our body too. And some people have edema, for example, in their legs get swollen. That's because maybe that fluid that seeps out from the blood vessels isn't getting collected in through the lymph system very well. So the lymphatic system is a parallel system to the blood vessels that has a different function. Oftentimes, cancers can jump into that lymph vessel and travel along it. The lymph vessels have these lymph nodes along the way. You can think of it like a bus station. And they get stuck at the bus station, and then they begin to proliferate there. So it's a good, when I talk about a surgeon taking out a lymph node, it's a diagnostic test really to see whether a cancer has spread from that tumor to that first bus station along the way.
But when you start thinking about taking 40 to 50 or 60 lymph nodes out, I mean, I can imagine
A lot of
the
problem.
inflammatory
Yes.
response.
Yes.
You're taking chunks out of my body.
Right.
Yeah.
The body's not going to, even a fat old body like mine, likes its chunks.
And your lymph nodes are part of your immune system, so their job is to filter things, tumors, infections, inflammation, that sort of thing, and help sequester something. So if you've had those lymph nodes taken out, they don't grow back, so you're also vulnerable for
So
infections
you
or
are
something there.
compromising the immune system as you remove more and more of them.
The more you remove, yes, right.
So now the imaging agents, does that help? I mean, can you give somebody a dye and, watch the lymph nodes light up and say, bad one, bad one? Oh, that's a good one. We'll leave that bus station intact.
Yeah, so sometimes you can, but really only if there's already a lot of cancer within a lymph node. When we talk about things that we can see on a scan, it's already a significant quantity of cancer cells. And when we talk about looking at it underneath a microscope, we're really looking at microscopic amounts that you could never even see on a scan. So scans are only so good. When a surgeon, and the surgeons do use something similar to what you say, they do apply a dye and even a little bit of a radioactive agent near the tumor, and then they can follow that dye and that radioactive agent to find that first lymph node that the tumor
That lights up.
Exactly, yeah, and then they can take it out, and the pathologist can look for that microscopic amount of cancer.
But now, Itai, you give me a radioactive marker, and it's going in my lymph nodes. Phew, like you said. I got an old heart. How do I protect the heart from, when I think of radiation in general, I mean, I'm an old man. I really don't want my heart going medium well. I'm joking, but how do you protect the heart and vital organs if you're putting in nuclear tracers, radioactive isotopes into the lymphatic system?
So, with those tiny amounts of radioactive tracers that the surgeons use for that procedure, you really don't worry about it because it's such a minute amount. Where we do think about it a lot, actually, is with the treatment of radiation. So, of course, with anything in medicine, it carries with it a risk of some kind of adverse effect. So we take a lot of care these days to minimize radiation from going to places where we don't want it to go. It's come a vast distance from where it was even 10 years ago, 20 years ago. It's constantly evolving. So these days, we take multiple precautions with the heart, with the lung, and there's various techniques that we use to try to protect those organs.
Besides cosmetics, is there really any difference the way you treat men or women? I mean, I got to believe a guy is less worried.
So with men, the standard treatment is mastectomy.
Yes.
Which is not the case for women. I do think that if a man had said, I would prefer a lumpectomy to a mastectomy, people would still do it. Because almost all men end up with radiation after they have a mastectomy. So.
I just remember they found a lump.
Yeah.
And they explained to me how they make a little tiny cut.
Yeah.
And I woke up, cut from one end to another.
Yeah.
And I said, excuse me, I signed up for the deluxe package, the one with, how come I got this economy tour? And he said, well, we thought it was yay big and turned out to be, much larger, and luckily it was just a cyst or something.
Okay, okay.
Of course, afterwards, when we had the longer discussion about what trauma my chest could have been through, I never thought that dropping down and stopping hockey pucks was considered trauma.
Oh,
Yes, the surgeon then explained to me that 90 mile an hour hockey pucks hitting your chest really are considered trauma, and I could get these benign cysts.
Right, right.
But it seemed like, okay, you're a guy, I'm not going to worry, just cut it, out it comes.
Right.
And candidly, I was one of those people who said, whatever it is, get it out. But I'm an old guy, who cares?
Right, right.
I shouldn't say who cares, but there's a less likelihood that I'm going to worry.
Right.
That I'm going to have any kind of adverse reaction from my darling bride. She's put up with me for 100 years. At this point, whether I'm cut or not,
right.
she's kind of stuck with me.
A few little wrinkles here.
What are the biggest concerns people bring to you when you say, I found some spots?
Well, I mean, I think when anyone gets a diagnosis of cancer, it completely changes their life, maybe for the rest of their life. Because even, we're curing the vast majority of our breast cancer patients, they're cured, but then they're still survivors, right? So they will have had breast cancer. In the back of their head, they might always be kind of worried, what if this comes back? So it's really, it's a huge deal. It's really a life-changing thing. And again, it's really good to go to a place that can offer you support services to help you not only with the cancer, but with everything that comes along with it.
But any oncology issue is not something that seems like you want to take on yourself.
Right.
It's not, I am man, strong, right? I'll see through this. Yes, idiot. Whether it's you or your family.
Right, right.
I mean, if you really do care, it seems like get over the ego and go listen.
Right.
Because like you mentioned before, I may be thinking I'm being supportive and I'm not getting the reaction that, okay, if I do this, I should get this feedback. And it could be very normal that you don't.
But because it's terrifying, and there's always that fear of, is this going to come back, and is it going to kill me, and am I going to die from it? So it's always important for you to be supportive, and I think the other thing is that there are some people who have better support networks than others, and so it's hard to reach out, but it is a time to ask people for help, or if people offer to help,
accept it.
Accept it. It's not easy to do, particularly for women who are accustomed to being the caregivers and always in control of everything. It's very hard for them, but
Well,
but
being
if
very
people,
self-centered, I can't imagine what I would do.
That's right.
We've been married 100 years. Why
That's
she
right.
puts up with me, I don't know. But the idea of not having her around,
it's terrifying.
Right. And if somebody in my family gets diagnosed, whatever terror I'm going through has to be 2 orders of magnitude less
Right.
than what they're going through, whether they vocalize it or, demonstrate it or not.
lots of times I tell my patients, going through the treatments are hard, but all of a sudden they come to the end of the treatments and everybody around them thinks they should be happy, and all of a sudden they're feeling, oh no, now what? And so it's really, it's very scary, because becoming a survivor and learning how to cope with that is almost the more difficult part of the whole process. It's really it's a journey.
But now, Itai, you mentioned something that there's a worry of, okay, I got over this one. What's waiting for me down the road?
Right.
Will, it's a bad penny. Will it show back up?
Yeah.
5-year survival rate is 89%. Any idea what the 10-year or 15-year? I mean, if I make it through the first 5, is it a good diagnosis for the next 5?
Yeah, I would say most of these cancers, if they will recur, they tend to recur earlier. So, it's always good to make it to a certain point, because your chances of it coming back then are probably lower.
Right.
So if I've made it through the 5 years,
Yes.
I know it's going to be hard to say, it's okay, Todd, you can relax now.
So what I tell patients is that most recurrences occur within the first 3 years. When the 5-year, we used to have that 5-year cure thing, but we don't say that, particularly with breast cancer, we don't say that as much. And that it's unlikely that people will recur after 5 years, but it's not impossible. And so it's always important to be aware that there's a very small chance of recurrence, but that even if it does recur, it can be treated again. And that's the important thing. But in the meantime, you have to sort of learn to live your life without thinking about it.
Yeah.
And sometimes you have to think about it as almost a chronic illness, like diabetes or emphysema or something like that, that it needs treatment every once in a while, and then other times it's quiet. And so for some people, it does become a chronic disease that they live with. They don't die from it, but they have to live with it.
Now, when you say live with, I mean, you hear about hormone therapy.
Yes.
And you say high levels of estrogen can be an issue. What is hormone therapy then?
So it's generally, so we know that most breast cancers feed on estrogen. So what the hormone therapy is that we use nowadays are analogs and compounds that are estrogen-like, but they actually block the estrogen in your body. And so that's why removal of ovaries can be effective in some people, but otherwise it's a pill. And most women who are diagnosed with breast cancer nowadays, we always look under the microscope and we look to see whether the breast cancer is manufacturing estrogen or progesterone receptors. And if those tumors are estrogen and progesterone receptor producing, then we generally recommend a pill that someone will take for 5 or 10 years.
So you can do an estrogen receptor blocking
Yes, exactly.
agent.
Exactly. And that's what those pills are.
And what does that do? I mean, the body normally likes a certain amount of estrogen.
So it does cause side effects. It will give women hot flashes. It will put women through menopause, skin changes, those types of things. It can have effects on their bones. It can have effects on their uterus, that type of thing. But it has been very much demonstrated to be very effective. And in some cancers, more effective than chemotherapy and much less difficult. So it's
But again,
really
compared to door number 1, this seems,
Yeah.
and it's easier for me to say, I'm not going through the hot flashes.
right,
So it's
right,
easier to
right,
say,
right.
deal with it,
Right.
versus door number 1, which
Right.
nobody wants to choose, but
And if it's going to give you a 30% improvement in survival, then that's really worthwhile. Sometimes we have a conversation with a patient that this is going to help you 3 or 4%. So you say, is it worth it for me? And those are the decisions that people have to make. But these are not one-way streets, these decisions. So I think that that's important
well,
also.
I mean, isn't that in every medical, in any indication? I mean, if there was the book that says, if the indication is X, do Y,
Right.
we would not need physicians.
That's not what medicine is about.
You know,
right.
you would need just somebody to implement.
Right.
Take this pill, life is good. I
Right.
mean, isn't that why you spend half your life? It seems like you finally get to practice when you're almost ready to retire.
Well, the
man.
best computers that are out there now, believe me, they're trying to create all these algorithms so that a computer will be able to feed it the symptoms that you're having, and it'll tell you exactly what the problem is. Doctors are still better.
Well, you sit there and say, no matter what, we already said you want to check with different oncology specialists.
Right.
I don't want to see a laptop in front of me saying, here's the printout, go to
Right.
the pharmacy, order these 3 things, and statistically, this should work.
For now, we're not there yet. Who knows? But
Yeah, I don't want to know about these statistically, this should work. You know, because again, 99% of the people survive.
But if you're that 1%, yeah.
Sorry, you're one of the
it's
1%.
bad.
I got to
It's
fix
bad.
my algorithm.
Right, right. But that's what life is, and that's what medicine is. It's just not an exact science, and there are times when you think things should be going in a good direction, and they don't, and vice versa. And, you know, we...
Yeah.
But now, the psychological part has got to be helped by being in Milford for people from Milford.
Yeah.
Because I know when my mom went through intestinal cancer over 10 years ago, it was so nice that she was staying in her town.
Right.
You know, her, we can't call it little hospital. Frank gets mad at me.
No, not anymore.
Not the little red
Not
hospital that I was
anymore.
born in.
It's
You
pretty
know,
amazing.
the cancer treatments available here rival anything
Oh,
that
yeah,
you can
no
get in
question.
Boston.
Yeah. It's been such a privilege to be here for the past 8 years, and it's been so emotional for all of us to see how worthwhile it is. And I love to tell the story of one of our physicists was coming on the turnpike, because he lived in Cambridge, and was coming on the turnpike and getting off, and he had his badge on. And this is when we were still paying with the tolls, and the gentleman, the toll collector, said to him, "Oh, you work at the cancer center, my mother was treated there." He said, "I can't thank you enough, because it just changed our lives." And to have to, because our treatments are given 5 days a week for up to 9 weeks, and so if people had to drive into Boston for all of those treatments, they wouldn't be able to do it. They couldn't, their family couldn't manage, financially they couldn't, they'd lose their jobs, all sorts of things. So
Well, the
it's
other
amazing.
thing too is, I mean, my mother's 91.
Wow.
So
that's
she goes back
amazing.
periodically, and it's always to Mona.
Of
Yeah,
course.
and it's not this oncologist, you know,
Right,
it's
right.
Mona.
Mona, yeah.
She's been there forever.
Yeah, yep,
And there's something special about the Milford Medical Center when you say, I've been there 8 years.
yeah,
You know, it's been one person
right,
treating my mother. And
Right,
even for
right,
me,
right,
I feel so much more comfortable
right.
that it's the same person.
And Mona had a vision. I mean, she used to have one oncology chair right next to the emergency room, and, you know, and they had two chairs for chemotherapy, just sitting the way we did. And then she really had this vision, and she and Frank carried it through. And to their credit, it's really just been
Yeah,
amazing.
you see it throughout.
Yeah.
You know, that
Yeah.
how many people aren't at Milford Regional for a year. You know, it's
It's
not
true.
a year and gone.
Right, right.
You see people well established,
Yeah.
and how do I say, their skill level is so impressive, because this isn't like, well, Itai couldn't get a job anywhere else.
No,
Right?
hardly.
So he's sitting in Haifa saying, well, nobody will take me. I'll go to Milford. You know, I mean, 3,000 miles he travels, and
Right.
he ends up here at the center of
Right,
the universe.
right.
But he stayed,
Oh, yeah,
you know, and you've been here 8 years.
yeah.
It says something about the staff, the environment.
It's a family, and it's a very supportive environment, and the resources have been extraordinary, and the support that we've gotten from Milford and the support that Boston has. The Milford Medical Center is a model for how to do community medicine at the highest level. You know, it's really, there are very few things that people need to travel
Well,
for.
we do thank you. And as always, to our 6 loyal viewers, I think the take-home message is make an informed decision. Get out. You have all the resources in the world available, and ties to specialists if you're one of the 1% that needs it. But it's incredible what's available here at the Regional Medical Center. Please take advantage of it. And to our loyal 6 viewers, hope you never have to deal with an oncologist, but if you do, you know you're safe and you'll be well taken care of. So may God bless. Good night. May tomorrow be a healthier day than today, and thank you for everything you do.
Thank you.
Thank you very much. It's been a privilege.
Not too long since I've been home.